So I'm a pleasure to have my friend Mohen. He's from Hyderabad, an expert for pancreatopillary and also third space. So as you heard the history, this patient is 71 years old and labeled as a difficult stone. So this is very good terminology. So it means multiple intrahepatic and probably impacted stones. She underwent multiple ERCPs and then therapy. So then I'm not sure about how many ERCP. So, but still there is a stones, and we have to make sure about the duct clearance. And today, our role, me and my friend Mayan, to do good cholangiogram, and then if there is any large stones, difficult stones, multiple stones, and then you have to plan about cholangioscopy and the role of the cholangioscopy. Did you have the cholangiogram? Cholangiogram now. So what do you think? Is it stones, multiple stones? Is it intrahepatic? Nowadays, I think cholangioscopy is a very cost-effective.
Yeah.
If you compare it to the patient who underwent 6 ERCPs and 6 plastic stents and a lot of accessories, the cost, I think, is more costly than performing one cholangioscopy and you complete the patient.
Yeah.
What do you think, Mohan?
Yeah, and this question is very valid, that when will you enlarge the sphincter? So I always see the relative size of stone versus lower CBD. If a stone is too large as compared to lower CBD, even doing a big sphincteroplasty is not going to help. And at that time, we decide that he needs a lithotripsy, either in the form of intraductal lithotripsy like cholangioscopy, or extracorporeal lithotripsy, or mechanical lithotripsy. But if the lower CBD is like a cylinder, like in this case, where we can do a good sphincteroplasty and remove the stone, but I can see the stone which is in the common hepatic duct is impacted, and we must interrogate that area by cholangioscope. What is happening there? Why so many ERCP have failed?
Do you think there's any other pathology, for example?
I mean, I'm not very sure, but I have some doubt that there can.
So I prefer myself to be lowered down and then without any pressure, so controlling the wheels of the cholangioscopy, and then also moving the duodenoscope right and left to.
If you feel that the previous sphincterotomy is not adequate, you can do a small balloon dilatation, say for example 1 centimeter, based on the lower CBD anatomy. Always compare the lower CBD with your size of balloon.
Okay.
So that's very important.
So as you see, me and Mohen, we agreed to cannulate without a wire. You see the good sphincterotomy, and then either you use the shaft of the duodenoscope, or you have to be very close to the papilla if you have good opening. Now I'm pushing the cholangioscopy little bit and controlled by elevators.
Yeah.
I'm in. Yeah. So once you are in, you have to be stable position, and then both of you compare the complications of cholangioscopy compared to the standard ERCP. I think the only high risk of cholangitis. So you have to give antibiotics. So you see do you see now the cholangioscopy image? The microtech cholangioscopy, as you see, the image is different. So now, as you see, clearly now the picture is different now.
Yeah.
What do you think, Mohin?
We must go more inside. I think that we can see a lot of mucin there. Can we go in more and see? Yeah.
I mean, the papillary projection that we're seeing can be just reactive, but if we can have a better view.
So what do you think about this, Jinan? Did you see the cholangioscopy image?
Yes.
Seen on imaging, like MRCD.
So there was no suspicion of any mass on any imaging. And this patient has been referred for management of stone. And we can see a stricture there. And whenever we interrogate a stricture by cholangioscopy, we always see for tumor vessels. And there are papillary projections.
Make it bigger, Amar.
There is a mass-like projection there.
So you have to have cholangioscopy, and the role of the cholangioscopy in this case is very,
Very important.
Now, planning to use lithotripsy, so I think we have to break down all these stones and then easy to be removed. So what do you? Okay.
So we are not sure what is the clip on right side, but that's a very important point which you have made, that this can be a Mirzi syndrome, but complicating into a stricture once post-surgery, because the way the cholangioscopy is crossing this stricture very easily without any pressure, it looks like to be a benign stricture and right at this area of cystic duct. So the plan would be to crush the stone, take the biopsy from the stricture, and maybe a fully covered stent for 2-3 months till we are sure that it is not malignant. The histology will tell us. And through this fully covered stent, the stone fragments comes out and the stricture also resolves.
Good. Sometimes will be one session. As you see, me and Dr. Mohen, we agreed to use the AHL. So most of the stone is fragmented. See now, this is the good fragmentation of the stone. The effect of...
So we have EHL and laser available.
Yes.
So laser has got a high investment, but the recurrent cost is much less and it's more tissue friendly. While in EHL we have, once the probe is broken, that means you have to, you have to reuse it. You cannot reuse it. So we cut the laser fiber as the
you
time
collaborate
progress.
the fiber, yes.
So that's how we are using more laser, and laser has got more, the probability of matching the stone density. If the stone is small, we use more higher frequency so that it does not run away from you.
Yes.
So higher the frequency, the more is the pulverization, what we call as a sanding technique or dusting technique, where it turns into dust, but it stays there.
So plan for this patient Jesse will give you a plan. So
we have a
Dr.
question
Abid,
here.
good morning,
Yes.
Abid and Mohan.
Yes.
So just
Please.
a question. So you have a stricture and you're going to break the stones, but you have a distal stricture.
Okay.
Yes.
Which you think it's benign. So would
Yes.
you,
Wait.
would you dilate?
Yeah. So a plan is to do, so benign biliary strictures are managed either by multiple plastic stents or fully covered stents. So we have done the randomized control trial, which has clearly shown that fully covered stent is equal to multiple plastic stent, but it requires only one session. So that if you put a fully covered stent, you pulverize the stone to the maximum, put a fully covered stent, dilate the stricture, and put a one plastic stent as an anchor, and all the fragments of stones will come out, and once 3 months or 6 months you can call the patient back, remove the stent, and the stricture will be resolved.
Okay, thank you. So the plan to create the stone and to put the fully covered stent with the plastic. Thank you.